Uh, First of all, let me introduce my business partner, Kevin Berger. Kevin is a partner of Phoenix Pediatrics. He is also the medical director for Hospice of Arizona. Sorry, Hospice of the Valley, and he's also board certified in palliative care. Uh, it's, Anything else I'm missing? All right, I think that sums it up. And for those who don't know me, I'm Brad Golner, and I'm the Eddie chapter champion for Arizona. I'm also on the AAP Eddie task force. So the way we're going to start this is I'm actually going to have Dr. Berger discuss about medical home and how it relates to children with special health care needs, and I'm going to follow that up with the with Eddie and the new Equip module that the AAP has put out and that I helped design. Kevin.
Thanks, Brett. Thanks for the introduction. I'm going to step over into the middle and just let me know if I need to move around and get out of the way. Um, I think that the topic of medical home is pretty intense and it's quite a lot to cover. So I'm going to go as fast as I can and as brief as I can, but try and hit the high points. It's certainly the high points that are important to me. Um, when I think about medical home, I think the whole concept of medical home was born out of children with special healthcare needs because you really need to adapt your practice to be able to take care of whatever somebody may need. And the concept of medical home is exactly that. It's a philosophy, it's a concept, it's not a place. I often get a question, and I get this with hospice as well. It's like, oh, so where is your hospice? It's like, well, uh, you know, um, I don't really know how to answer that. And where is your medical home? Well, I practice out of an office, but the concept of medical home is about how you take care of people. It's not where you take care of people, and how you provide the services that they need. The characteristics of the medical home are defined by the American Academy of Pediatrics. So, I tend not to focus on these words. They want us to have an accessible office. Well, to me, that makes sense. If somebody needs something when they need it, you need to be available. It needs to be family centered. Family centered care is a discussion on its own. And I think that a lot of the times we think about care as physicians, as what we can do for you. Well, that may not always translate what a particular family needs. And everybody's different. So if you go in with your preconceived ideas of, I only do this, this, and this, well, that may not be the right thing for somebody with, as an example, let's say you have a patient who has Tay Sachs disease. One family may choose to be very aggressive ventilators towards the end of life, and their prognosis that way may be 4 or 5 years. Another family may say, well, the surgeon told me that my baby can't eat anymore and I have to have a G tube, and there's no way I'm doing that. And so if you're providing that service and you're saying, well, everybody needs a G tube when you get to that point, um, you're not providing family centered care. And it depends on so many things about that family. It also needs to be comprehensive. So you need to be able to address all their needs. It doesn't mean that you have to be able to do everything. Like, I think as a resident in training, I always used to have this fear that, oh my gosh, I've got to do everything for a special needs child. And no, that's not the point. The point is that if you need a geneticist, I saw you, so I'm going to pick on you. If you need a neurologist, if you need somebody, what I need to know as a physician is who in our community can provide that service. Uh, Unfortunately, we don't have everything available, even in our community. We don't have the answers, and the obvious example that was just raised was transition. I think we're very much lacking in adult physicians who are willing and able to take care of children with special needs. Um, it also needs to be continuous. In other words, you need continuity of care. So if you can go in and see somebody who is familiar with your child, even if it's a few providers in a practice, and they all have access to the records, that is continuous care. It needs to be coordinated. So you need to be able to take all of those resources and all of the places that those people go to, and be able to communicate effectively, and coordinate that care. Um, and compassionate, I have a tough time with that because we're all supposed to be compassionate. So do we need to write that down? Anyway, We need to be compassionate. Um, and then culturally competent. That is kind of tough sometimes. I think all of us try our best. There are tons of resources through insurance companies, translation services. Um, but when you start talking about interdisciplinary care, I think that this helps out a lot with culturally competent care. I always know that I can't be everything to everybody. And so I like to think that I can be pretty good as a physician, but I'm not a great social worker. And so I got to know people who can help me out. Um, and sometimes that means somebody who is fluent in Vietnamese or whatever language it might be. And that's cultural competency. It doesn't mean that I have to do it all. So the challenges for the general pediatrician. So some of these things you may not think are relevant. I do think they're relevant because it undermines your basic ability to provide care. So um, the, the challenges are, number one is how do you establish that medical home? How do you set it up? Number two is our next one. How do you survive financially? And this is always a tough thing to talk about as a physician. You know, we're very, very, very wealthy people. Um, that was sarcasm, sorry. um, yeah, we do fine, but it takes a lot to run a practice. Um, and how do you build community relationships in order to be able to provide that care for children with complex chronic illnesses? Again, you can't be everything to everybody, so you need resources and you need to learn in your community who can do what. Um, so let's talk about establishing a medical home. You have to develop a practice culture. Um, in our practice, we have, when we recruit people, the one thing that we say to people, if you're not interested in seeing very complicated special needs children, don't work here. And that's the bottom line. Um, I think if you kind of like, well, I'm okay if you guys help out, whatever. No, you're going to have to learn and you're going to have to get yourself educated, and we'll help you with that. But if you don't want to, if you don't have a desire, there's another practice for you in town. You have to make a commitment, and there are a lot of financial risks. Um, and I'm going to explain those a little bit just with the basic concepts. But you have to make that commitment, and you just have to jump in and do it. And make sure that you can communicate that and collect data and communicate that to all of the interested parties, especially the payers. You develop systems, community relationships, and resources. We're big on systems in our office. If you have the same way of doing things, I always use the um, example of walking into a Target store. If you're traveling and you're in Portland, Oregon, or if you're in Phoenix, Arizona, I know if I walk into a Target that if I go down that way, there's going to be the automobile section and I know where to find things. Well, it kind of needs to be the same thing in healthcare, and we're terrible at that because we're all independent physicians, and so we're not so good at developing systems, collecting data and information, being specific. You know, what size G tube does your child have, so that when the next person comes and looks in the chart, they can't find it, and we've got to order a new G tube because it just popped out, and we've got to get one now. We've got 6 hours, so um, if we can do that and save an ER trip, it's happy for everybody. Um, Understanding the concepts of interdisciplinary care and family-centered care are huge. The American Academy of Pediatrics has policy statements on both of those, and anybody who's interested should read those because I think that we often just don't get it. The idea that the physician has to be everything to everybody or the leader of the team, to me is just years ago. So if you can use people who are good at what they do, it's fantastic. Um, you know, even yesterday we were talking about one of my patients who I had recently referred to hospice, and I have known this family for a long, long time. And the chaplain sits down at our interdisciplinary meeting and tells me things that I was just like, wow, really? That family has those kind of issues? I don't know anything about that. And it just goes to show that I have a focus. And so it takes a team. And my focus doesn't get everything. So next one. The additional challenges that we face, recruiting difficulties, how do you provide that higher level of care, and is everybody interested in doing that? How do you get people to educate themselves? it's not like caring for special needs kids is a specialty. And we're careful not to say that, we're specialists in this. We're not. We have an interest and we have a commitment. And we're good at it, but we're not specialists. Um, but you do have to kind of make a commitment and do that extra CME and make yourself an expert. So, what are the benefits of a medical home? Efficient use of resources. I often will get patients who have been elsewhere or, just kind of don't know how to access things. Um, and you kind of spin your wheels a little bit. And if you just know exactly where to go and who's good at what, and we can get you there, that's good use of resources. You get expanded expertise and competence, obviously. Um, it's also nice from my perspective to establish that forum where I can go to Dr. Gollner and say, hey, Brad, you know what? I just saw this kid and um, gosh, he had some hearing issues and, it's, am I that good about with that? No, it's not really my thing. And then we've got people who've got different interests and we can utilize each other that way. We get increased patient and family satisfaction, um, increased professional satisfaction. It's nice to work in an organized environment where you know that you've got backup, and obviously more efficiency for families. If you don't have to get your care in the emergency room, it's huge. And if we can save your hospitalization, that's also huge. Why? Because you get to go to school every day. Your life is not disrupted. Mom can go to work if that's possible. But that is important. What we want to do, to me, the outcome of my work is if that person can have as normal a life as possible, regardless of their disability. Great. Then we're doing our job. Um, so other benefits for the patient is access, obviously. Um, for the physician, the support systems. For the insurance companies benefit greatly. And sometimes making that um, uh, education piece, educating them that if you spend a little bit more to get an enhanced product and you get decreased utilization because you get proper utilization, you don't get all your care in the emergency room. Hospitalization that'll trigger case management, and they get involved, and it's kind of like a boom, boom, boom. Let's get this sorted out. Drop you off, stop utilizing, stop spending, and then they're out. It's not a long-term thing. So it's kind of like we can save money in the short run, and there's a place for case management. It helps to coordinate, especially when you're running around busy dealing with very sick kids in the hospital, and you don't have time to coordinate a lot of things. But case management is here and now. It's acute. It's not a long-term solution. So the difference, next slide. Um, with clinical care coordination, it's a process, and that process is continuous and it's long term. So, what we try and do is be available to coordinate that care, whatever it is, whatever situation it is. How can we help? It might be a letter of medical necessity, it might be prescriptions or letters to back up new DME that's required, and it's proactive. And so, we look at the kids and we say, okay, so you're coming to us. We're not waiting for people to come to us to ask us to get them things. We're trying to say, what do you have in place already? And if you've got this in place, great. But why don't you have this, this, and this? We're going to help you get it. And I've always had the philosophy that if you um, provide what people need in their daily lives, um, it's going to be a lot less expensive in the long run. So get the wheelchair ramp done in the house. Get the bathroom modification done. Does it mean that we're accessing resources that cost a lot of money? Sure. But if they're appropriate, you're entitled to it. I mean, that's what makes your life better. And so if it's an air mattress, if whatever it is that prevents complications down the line and provides some stability in your life so that you can have a routine and get up and do your thing every day, that's what works. And when you do that, that level of anxiety, that running to the ER in case there's something, um, it goes away. It's like, all right, I'm secure. I've got what I need. And if I don't have what I need, when it comes up, I know who to call. That's the medical home. Like that's kind of that security of knowing that you're going to get what you need to take care of your child or yourself, um, that's what makes the medical home. And it's that care coordination piece that provides that ability for people to do that. Because if you're just relying on a physician to do everything, it's not going to happen. So documentation. This is when we talk about systems. And I'm a pain about this, and Brad can back me up on that. I just kind of think that if it takes a team to take care of you, and in your records it doesn't say what size your G tube is, what formula you're on, what size diapers you need, whether or not you've got a wheelchair, whether you've got a handicap parking placard, and those things are not checked off every time, they just go by the wayside. And then it's a crisis when you need it. So if you can do that and you can do it systematically and it's available to everyone, it just makes everything flow nice and easy. When you need a letter of medical necessity, if that information is in the chart, it's boom, boom, boom. It's, you don't have to call back a million times or make somebody come for an appointment for that. It's just get it all done, make sure it's documented, and it's easy. So documentation needs to be uniform, it needs to be comprehensive, it needs to be standardized, so we are all talking the same language and we're all looking in the same place for it. And systems create efficiency. If you put a system in place, it's the same for everybody, it's all good. It also helps with reimbursement. So if an insurance company comes to me and says, well, what are you doing extra for my patients? Let me show you. I'll be happy to pull out the nice stack. And well, now it's all electronic, but we can show you all the details. So how do you survive financially? There's just two little concepts that I'll talk about. Okay, so it takes more time to talk about lots of things. So if you look at a typical pediatrician's schedule, or an adult physician who is used to or not used to taking kids with special needs, and they're looking at their practice and they're saying, all right, I book every 10 or 15 minutes. So it's 10, 15-minute slots. To address all of these issues, you've got to take more time. So if I've got my 1 hour, and the typical pediatrician is over here, and he sees 2 well checks, 2-month-old, 4-month-old, an ear pain, cold, and an add-on for that 5th appointment in that hour. He's seeing 5 patients in an hour. Well, in our office, we book out an hour for a long-term care well check. So I'm going to do that, and then I've got a code according to standards, and I give them a diagnosis, and it's a V20.2, and then there's a whole list of chronic illnesses, and some insurances pay for a modifier 25 that kind of allows you to bill for the extra things, and some don't. And there's an E&M code that goes with your office visit for a well check. Well, most plans don't account for anything extra, so you're going to get paid for doing that well check. So I'm doing the well check, and my colleague is doing, and I've done one in 1 hour, and my colleague has just billed 2 well checks and 3 sick visits in that same hour. How am I going to come out even? It's not going to happen. So this is just data that we collected in 2003, and I haven't updated the slide just because I like the slide, and it still says the same thing. But what you can look at is physician A, whose visits per week has about 4% of his patients as long-term care patients, special needs patients. Physician C over there has 20% of his schedule is filled with long-term care patients. So how many visits per week does that count to? That's 30 visits per week less based on our data. Okay, when the more long-term care in your schedule, the fewer kids that you see. Basic concept. Okay, next slide. Then we talk about work RVUs, and for relative value units is kind of a measure of what the value is of the code that you just kind of built for. So that's a very simple way of talking about that, but that's really how we get paid. Okay, so what's the value of an RVU? It varies. Some years it's about $30. It used to be about $40. I don't know. It depends. So if you look at the physician A, who was seeing 4% of his children as long-term care, and the amount of RVUs he generates per week, and physician E, who had 20%, that's a significant drop. 50 RVUs per week, multiply that by 30 or 40, that can be $100,000 a year. So you're asking a pediatrician to say, or an adult physician, say, hey, you know what? We've got a special deal for you. We want you to see all of these kids who are complicated, got lots of issues to deal with. There's a ton of paperwork afterwards. And by the way, we want to take you to take home $100,000 less a year. Okay, so that's not taken in overhead, but so it doesn't translate to that much. It's about $45,000, $50,000 a year less. But you need to work harder, do more complicated stuff, take on extra risk, and make less. Doesn't work in the real world. It's just we're altruistic, but yeah, whatever. Doesn't work. So we talk about non-face-to-face encounters. All the work that gets done outside of the office visit. So what you get paid for in an office is seeing patients. You don't get paid when you don't see people. So we do care planning, we do care coordination, we do record reviews. Tons of records come in. I mean, they have a lot of appointments and previous appointments, moving from another state, whatever it might be. There's a lot to look at. We've got to talk on the phone with specialists sometimes. We've got to read their notes. Takes a while. There's a lot of school issues that get involved as well. Missed days, planning for surgeries, things like that. Letters of medical necessity all the time. You need something. Um, is anything changing with your child? No. Do we still need to write a letter of medical necessity every few months? Sure. You've got to keep getting your services, sign up for your therapies, everything. New equipment. God forbid you should ask for something that's more than $1,000, which is most things. It takes a lot of time, and you've got to get a lot of backup documentation. You've got to get letters from the therapist, get it all together, and get it in. So those are the things that you don't get paid for. So we talk about the scheduling and lost revenue, not being able to see as many patients as somebody else. You talk about overhead and additional personnel. We employ good people who can help us do this. So if you add an RN, if you add a care coordinator to your staff, that costs money. They don't do that for free. We have additional personnel, obviously. We have all the non-face-to-face encounters. We have the complexity. And the RBRVS, the RVU system that we were talking about, doesn't have a conversion factor for complexity. It's like they're not going to come and say to pediatrician X, like, oh, thanks for taking care of the complex things that, you can walk in and out of a room and look at ears and do your spiel and talk about constipation and whatever. It doesn't take a whole lot of energy. Yeah, you got to stay upbeat, but, it doesn't take a lot of extra brain power. Next one. So other partnerships, professional organizations that we've been involved with over the years, and I think this is also kind of being a medical home. It's not a standalone kind of situation. It doesn't work as a standalone. You've got to be involved with your American Academy of Pediatrics. You've got to be involved with your local chapters. There's a council on children with disabilities through the American Academy of Pediatrics. And these kind of things help with your own education. Parent advocacy groups. We have some great organizations that we try and be involved with, or at least refer to. If I can, sometimes, I'll try and do a lot of work with a patient, and then I'll refer them to someone else, and they'll go to, let's say, Raising Special Kids, and they'll meet up with a mom and get tons of information that I'd been trying to share that information, but when it came from another mother or another parent, it's like, oh, now it makes sense, And obviously, I mean, I think that there are things that I don't get in a way that a parent can tell somebody else. And then charitable organizations. I think we've got to support those. We've got to support people who raise money, who do things for services that are not covered. A place like Ryan House that provides free respite for people. It's all based on donations. And so if I can do something to raise money and get involved, I think those are all just important things. Does take time though. Long-term care facilities, we've always had a relationship with Hacienda. They see a lot of kids. Hospice programs, Hospice of the Valley and Ryan House. Hospice of the Valley has been doing, this is a little bit of a shameless plug for me, but I've been working for Hospice of the Valley for 11 years now. And just the Um, the basic philosophy for me when I go and I ask for something that's not a covered benefit or the child has no resources, I have never in 11 years been turned away and said, oh no, we're not paying for that. And it's kind of, I just explain myself. It's like, why do we need this? Or is it, sure, yeah, go ahead. And I don't know if we all appreciate what that means, in big organizations and how that impacts people and the care that we provide. It's amazing. So, and then the insurance companies. Well, um, we have some great relationships, and then we have relationships where people don't get it. Um, you've are we asking to provide more for people who consume more resources? Yes, we are. Is it going to cost you more money? You may think so, but it doesn't. It actually is going to save you money if you do it right. Take care of them right, and it will be cheaper. And we can demonstrate that to you. And it's kind of a hard sell sometimes, but it takes a little bit of understanding, it takes compassion, and it takes sometimes just doing the right thing. So, um, but we're willing to keep at it. Um, I think that I'm running out of time, right? Okay, so I'm going to just breeze over these. When you see a lot of special needs children, people, um, you get referred our practice. We don't say no to anybody. No, that's too complicated. Oh, you're on a ventilator. Oh, we can't see you. So what happens is that you get kids referred to you who have terminal illnesses. And sometimes it's 100%, and sometimes we have no idea what the prognosis is, but it's potentially terminal. And so there's a reality about this, that children die, and that's why I've been involved with hospice. Um, Children die, and this is just the statistics. Um, this was the first patient I ever took care of on hospice, and I was in Houston, and I get a call from this patient's mom, and he had Tay-Sachs disease, and she says to me, so, hey, do you know Marsha Levittown? So I said, nah, don't know her. Well, she does pediatric hospice. Do you know what that is? And now this is about 15, 16 years ago, actually. And I said, nah, I didn't have any training on that in my residency. And, well, do you think it sounds kind of wacky? Yeah, maybe. I don't know. Let me talk to her. So I call her on the phone and we have this great discussion. And I said, all right, where can I refer this kid to you? She says, no, no, no. You're doing this yourself. I'll help you. And that was like life-changing for me. And it's probably the reason why I do what I do these days. So uh, this little boy never went to the hospital once. He died when he was 22 months old. They chose not to do any G tubes. They had one emergency room visit for a temperature of 106. And then when the doctor said, well, we want to do this, this, and this to him, they said, thanks, we're going to go follow up with our pediatrician. And it was awesome. So just a very good experience. Next slide. The other thing that I was talking about is, family-centered care. This little baby had trisomy 13, and the parents obviously chose to put in an NG tube. Some choose not to. Their goal was to get to the beach. Okay. So what we did for this family was, this picture was actually taken on the beach. And it was the middle of winter, so she was bundled up, but they wanted to go to the beach. So they went to San Diego, and she came home after that and died shortly after. Babies typically, on average, about 4 weeks, will pass away. But we've got some who survive months. And so, when we're talking 7, 8, 9 months, and you've got trisomy 13, we have a discussion with the insurance company because they've been on hospice for more than 6 months. Okay, we'll talk. Um, so there's always challenges. There's always changes. We're going to go through a change now with CRS and everything else, and who knows what else is happening with ACOs and whatever. I think as long as there are people who are pushing ahead, trying to make changes, we just keep going. So I'll hand over to Brad. Thank you.
Thank you, Kevin. So how does the medical home translate to hearing? Why is the AAP so interested in hearing? EDI, Early Hearing Detection Intervention. Why was it created? Why is EDI part of the newborn screening program or partnership here in Arizona? Well, here's how it translates. First of all, it's important to understand that Congenital hearing loss is the most common congenital birth defect that we see. 3 to 4 out of every 1,000 babies born are born with deafness, or mild to moderate deafness. Now, why is that an issue? Because financially it becomes an issue. So, for example, the John Tracy Clinic in California estimated that the cost to society for one child who has profound hearing loss at birth can be up to $500,000 as far as over their lifetime. What does that mean? Because of services such as early intervention, therapies, uh, medical equipment, special education, loss of revenue secondary to disabilities. So all that summarizes up to about $500,000 per patient, particularly those who are not diagnosed early. Why is so? I like to, and this has been actually this was actually a phrase coined, I think, by Dr. Albert Mell from Colorado, who said that newborn hearing loss is a quote developmental emergency. Okay, so us as pediatricians, we are developmental experts. Our job is to make sure that kids are developing appropriately, and if we miss hearing loss as an infant, that child will have a developmental delay. Because if the inputs are not getting into that brain when that brain is developing, that child doesn't learn. So that's why it's an important issue. Now, that brings us up to the things I'm going to talk about is the EQUIP module. So for all pediatricians, unless you've grandfathered out, maintenance of certification, the MOC, everybody knows what that is. Everybody kind of, my role, of course, as the Eddie chapter champion for Arizona and being on the task force was to help develop the hearing component of the EQUIP module. So some of the things that are important with the relationship to medical home is establishing for that pediatrician techniques and finding ways in their own practice how to improve upon managing that child, identifying that child, but more importantly, managing that child, making sure that that child has the appropriate referrals, the appropriate follow-up. So, for example, one aspect is to a lot of the questions that are asked in the module or that you are forced to do as a pediatrician is to look at your charts, look at your medical records, whether it be paper or electronic, and to identify patients that you've already seen. Have they been screened for their hearing? Do you know the results? If there is a result where a child did not pass their hearing screen, what has been done? So those are some of the questions that make the pediatrician think about, do I have my systems in place? Is my office set up to adequately treat or refer this child? So how are those systems done? And the whole purpose of the EQUIP module is to improve upon your practice. Easy examples could be like, have you flagged that chart if that child didn't pass? If you've never seen this child before, and now you're seeing this child for the first time at 2 months of age, do you know the hearing results? Is it readily available in your chart? Or if that baby shows up to your office for the very first time, do you know the results? How do you know the results? What do you do with the results, particularly if that child did not pass? So that's the whole purpose of the screening module, of the EQUIP module. Other things that go into play, and this is an important part of the medical home too, is have you addressed parental concerns? Have you explained the results? Have you given the parents all the options of what they need to know moving forward? And have you done anything as far as long-term follow-up for these children? Again, parts of the medical home correlation with the EQUIP module. And bottom line is, does it or can you improve upon your practice as far as systems that you have going on right now? How can you improve those? So that's the whole idea. It is a fairly long process in doing it because it requires lots of charts within your office to research and to find where you can find improvement. But something that Dr. Berger alluded to also is that you have to have a team approach. Everybody in your office has to be able to be on the same page to coordinate everything together so you can be successful. And the same thing goes with the equip modules, where you have to be able to identify areas in your office that need improvement, and how can you implement that improvement. So that's the whole idea behind the course. Now, the beautiful thing about it is, I, when I was constructing the hearing component of the newborn screening module, um, the nice thing was we are also able to use a lot of case studies in there, and so like things that pediatricians may run across that can be a challenge. How do you respond, to this particular patient, or how do you respond to these particular parents' concerns or denials of their child's condition, things of that sort. So it really is a good educational piece. And that is really actually the word I want to focus on, education. Because the one big thing that we're trying to push very hard as far as Eddie is concerned is physician education. One of the things that we have concerns as far as our hearing screening program throughout the country is, are PCPs educated enough to know what to do if a child is born with a hearing deficit, or even a late onset hearing deficit? What does the pediatrician do? And so that's part of the equip module benefit also, because it really goes into great detail as far as educating PCPs in what to do for that newborn, whether they pass or fail that newborn screening, or if there are risk factors for late onset hearing loss. Those are the highlights of the equip module. Any questions? Oh, good question. So the question was, is there a way to track like how many physicians are using the equip module, or even within our state, Arizona, how many physicians are doing this? And that I'm not sure of. Certainly the AEP might have that answer though. Yes, and there are multiple different equip modules, and this is just one of the newer ones that have come out. And of course, I'm a bit biased because hearing is a big important thing for me, and of course I try to say that, hey, this is the best one because I'm pretty sure of it, and but it's an important one because that goes in line with what the Eddie Task Force is trying to do. Is nationwide we're trying to educate our PCPs as far as newborn hearing screening. Yeah, and that would be really probably up to the um, the Organization for Family Practice. Peggy, do you have a comment? Great, thank you very much.